Welcome to another episode of the Your Longevity Blueprint podcast. Today, my guest is Yvonne Karney, who is a medical doctor traditionally trained in gynecology and who is a former United States Air Force physician who converted to integrative medicine when she realized she didn't have the right tools to help her patients achieve true health. She's the founder of Vitality Renewal Functional Medicine in the Chicago suburbs, where her newest venture is to revolutionize breast imaging by offering an option that has the image quality of MRI without radiation, IV contrast, or painful compression. She's on a mission to give women options for breast imaging and educate them about the risks and benefits of the current breast cancer screening recommendations. That's exactly what we want to talk about today. Welcome to the show, Dr. Carney. Yeah.
Hi, Dr. Stephanie. So nice to be with you today.
So I met you years ago in our healthcare entrepreneur mastermind group, but I only recently found out in 2024 that you had this breast QT scanner, if that's what I call it, if I'm saying that right.
Mhm.
So I had to try it out for myself. And knowing I was finished breastfeeding in 2024, yeah, summer 2025, I took a trip up to visit your clinic near Chicago again with my mother, and we both experienced this scanner. I posted on social media and I already had a bunch of questions, and everyone wants to know all the juicy details about this this scanner.
Great.
So after that experience, I knew I wanted to share this with my audience, and hence here you are. So the topic of today is to talk about breast imaging and what better options exist. But I have to hear your story first. So before we get to that, tell us about yourself. So you worked in the Air Force. Tell us how you got into functional medicine, what your history is, and then we'll get into breast screening.
Yes. Okay. It's a great question. And I admire people who knew about natural health and integrative health from the beginning.
Yeah, that was me. I
And
got lucky. I got
and
lucky.
I have to tell you, I was not one of those people. I had not even heard of a naturopathic physician or anything like that prior. I was dyed in the wool, a medical doctor. I went through medical school, and the United States Air Force paid for it on scholarship, and then I served them for 8 years as a Air Force doctor. And so the training, in the military, you don't ask a lot of, you don't ask questions that as to why we do this. You just do it, right? Yes, sir, no, sir, follow the algorithm. It was a very academic program, which was great. I got good training. But really the training was follow the algorithms because they're there for a reason. And this is how we practice medicine. And if you
Yeah.
follow the algorithms, you'll stay out of trouble. And so it wasn't until I started, number one, with my own health problems, realizing that I wasn't living the healthy lifestyle that I needed to keep the rigorous nature of my profession up. And then as a gynecologist, listening to women talk about their struggles and realizing, oh my God, I don't have the tools to help them, right? Because there's got to be more than take birth control pills or an antidepressant or do surgery. And so that's when I was like, there's more out there. And so as I started learning these things, I was like, oh my goodness, I didn't know all this. And once you learn it, you cannot unlearn it. So in 2016, I left my practice and started my own functional medicine practice in the same town that I live in. And so it's been a wild ride since then.
So tell us when you added this QT scanner. Tell us when you heard about it.
I first heard about it in the fall of 2023 and felt, from someone in the same mastermind that you and I were in
Yeah, yeah,
together,
yeah,
but
yeah.
I think you had already left. But yeah, no, a gal she's actually, we have a company now that we're partnering together to try to bring this out to women. She knew the inventor because her practice is in Northern California and she had heard of it and she was referring patients. That was about a 2 hour drive from where she lived down to where this machine was just north of San Francisco. And once I heard about it and learned more and more, we decided that we needed to bring it to women. And so it's been a labor of love and trailblazing and all the things that you can imagine as you bring in a new technology. I I was trained to give women a mammogram prescription. And as a gynecologist, that was a key component of my exams with women, right? And I thought I was helping them. And in a lot of women, I'm not here to badmouth mammograms. What I'm here to do though is say we need to have an honest conversation about them
Yes, yes.
because nobody is really told about risk benefits or alternatives. They're just given a prescription. And then they're somewhat shamed if they don't get it. Like, well, what are you inviting? Advanced breast cancer? Wouldn't you want to catch it early? You're taking an undue risk with your health. You have family relying on you. You need to get screened for breast cancer. And then, the CDC estimates that 30 to 40% of women that are of mammogram age are opting out.
Wow.
Well, so how guilty are those women feeling that they're putting their health at risk and all of that? So I want to reach those women. And I also just want to reach the people who are like, well, what is a mammogram and what is breast cancer screening? And how come nobody's ever talked to me about, limitations, risks, benefits? And that's a key component to good medicine, right? It
Mm-hmm.
means that we trust our patients to make decisions for themselves. We don't just hand them a prescription and say, do it because I said so and I'm the doctor. You talk about risks and benefits and alternatives, and you say, here you go. What do you want to do with this? And honor their autonomy and their brain to make decisions for their own health. And so that's my mission now.
I love it. I'm sure many of my listeners are saying, that's me, that's me. I've opted out of mammograms. So now what do I do? Because no, I obviously don't want to miss a breast cancer. Patients aren't intentionally wanting to, not screen themselves. Um,
Right.
I'm going to pause just for a second here, just because I welcomed your note takers into Zoom and now they're down below. Should I, do you see
Can we
how
get
they,
rid of them? Yeah, get rid of
well,
them, boot
should
them
I,
out.
okay. So how do I get them out? What do I do? I can't really kick
Can you
someone out.
click on participants
I can, I
and
can,
can you remove them?
oh, I can. Okay. I've
There you
never
go.
actually done that. Okay. Um,
So if you have a
Sorry.
belligerent, no, no, no,
Sorry.
there we go.
Okay. It's running some little report and then we'll continue. Okay, so we'll continue. We'll edit that out. So before we get to this new latest and greatest, what I think is probably the best current breast cancer screening option we have, let's talk about the bad first. So kind of tell me what's wrong with our current breast cancer screening situation.
I'd like to put that into two
Yeah,
categories,
yeah,
and
sure. Take
one
it
would
away.
be limitations
Okay.
and the other is risk.
Okay.
But honestly, there's benefits too, right? So the benefit of any breast cancer screening program is to catch cancer early. And so that's a true benefit because the earlier something is caught, the easier it is to treat. There's a huge difference between a lumpectomy for a, 3 millimeter lesion than a mastectomy for a 3 centimeter lesion, or whether you need chemo afterwards. So
Sure.
early detection is clearly an advantage cosmetically. The one thing that we don't know for sure is whether it actually saves lives. There was a study out of Canada, and this was crazy, but a study out of Canada that said that the best way to save your life is do a self breast exam.
Wow.
Yeah, because the treatment for cancer is so advanced now that the mortality rate is actually very low, even if it's caught later. But it's so much easier to treat, right? Who wants to go through all those other things?
Sure.
So there are benefits of any screening modality. There needs to be benefits. So limitations means what can't it do? Right? So things that it's maybe not as good as we had hoped. That would be a limitation. What can't it do? And risk implies that it could actually cause harm. And so there's a distinction there that I just want to be upfront about. So as far as limitations, there's three, and one is false positives. So this is where I am going to just show you a little picture.
I remember you sharing this information at A4M when you spoke last year, and
Oh,
this
yes.
is, yeah, surprising. Good to be sharing today, though. So she's
So
sharing a slide here. Yep, go ahead.
yeah, so for every one woman diagnosed with breast cancer, 19 women have an abnormal mammogram and undergo multiple procedures to prove that they don't have cancer. And that means 95% of mammograms that are abnormal are false positive. So that's good for the woman. I'm glad she doesn't have
Sure,
cancer, but
sure.
that's a lot of anxiety for the
Oh
19
yeah,
women that are told that there's something wrong and they need a callback. And so when they get the callback, sometimes they get a handheld ultrasound, sometimes they get an MRI, which requires gadolinium, which is a heavy metal through an IV.
Yep.
And sometimes they get a breast biopsy, and sometimes they get all three. And so there's this lag time where oh my God, my first mammogram was abnormal and I had to go get a biopsy and I was scared to death that what happens if it turns out cancer. So until you get that all clear, it's very, very anxiety provoking. And then there's risks too, because the biopsy risk is that it's a needle, there's infection, there's hematoma. So there's numerous reports of hematomas from a biopsy that needed to be surgical drained.
Yikes.
And 80% of biopsies are benign. So not only just 95% of abnormal mammograms are not cancer, even when a biopsy is recommended, 80% of biopsies are benign. Again, I'm glad the women don't have
Sure,
cancer,
sure.
but why are we putting needles in so many women's breasts to prove that they don't have cancer? And so that is a big limitation is
False positives.
false
Yep.
positives. So then another limitation is false negative, which means the woman has a problem that could be serious, but the mammogram doesn't pick it up. And that is seen specifically in women with dense breasts, which is almost 50% of the population. And the reason for that is that mammograms, the beauty of the x-rays that picks up calcium deposits that are abnormal. So not all calcium deposits are abnormal, but there are some that are. And if they're abnormal, then that's because the blood vessel architecture in a tumor is not normal and it shows up as these microcalcifications. And so you can pick those up at the millimeter size, um, which is great because then it's early detection. But if a woman has dense breasts, then the breasts look white on mammogram,
So then are
and
they
the calcium
recommended?
deposits are white.
So are then they recommended an MRI, or usually are then they recommended the ultrasound to follow
So
up?
now the FDA in the last year has mandated that women with dense breasts that meet a certain criteria, which is only diagnosable on mammogram. So if they have a mammogram and there's a certain amount of whiteness in the review of the films, then it's called dense breast limitation, and those women are offered an ultrasound. And the ultrasound would pick up, this is a handheld ultrasound, so it would pick up things that are probably, I don't know the limitations of ultrasound, but it's not a millimeter.
Sure.
So it's still going to miss the small ones in dense breasts. It's like finding a polar bear in a snowstorm if you're looking for white calcium deposits in a very dense breast. So that's false negatives. And when you consider that, up to 50% of the population has dense breasts, and the younger the woman,
Mhm.
the more likely she is to have dense breasts. And who are the ones that are starting breast cancer screening early are the ones with a family history. So they're more likely to start early, have more screens,
They're getting more radiation.
more
Oh, yeah.
radiation, more dense breasts, more callbacks because they didn't get a good view. So it's a dilemma. And then the third limitation is overdiagnosis, which is a little complicated, but what that means, and we know this happens, is that there are forms of cancer that are so slow growing that they would never shorten a person's life. For instance, if you're 55 and you have a very, very slow growing cancer, you're going to die at the age of 95 in your sleep with this tumor that never caused you an iota of problems, but it was there for 40 years. But when you start doing imaging studies, so this is
And
a
you're looking
disadvantage,
for problems. Yeah,
you're
yeah.
looking for it. And so when you see it, you're going to treat it. No doctor's going to watch cancer once they know that it's there because you don't
Mhm.
know which ones are the slow growing or not. So they want to treat it. And then you're looking at how many surgeries, radiation therapy, and all that have been done for cancers that are considered so slow growing that they would never have
Killed
jeopardized the
someone. Yeah,
woman's
yeah.
lifetime. And then what is the number one risk to a woman's health after breast cancer treatment? Heart disease. And it's because of the radiation to the chest damages the cardiac muscle.
Makes sense. Yeah.
So then, that creates a dilemma that, you know, the
Yeah.
study from 2016 said that about they calculated that 40% overdiagnosis of cancer. It was age dependent. For
Wow.
women who started mammogram screening 40 to 49, it was a 40% overdiagnosis, meaning those tumors were 40% likely to never have caused a problem in the woman. And for
Wow.
women's 50 to 59-year-old, it dropped to 30%. So those are where, like, when these committees get together and they decide when should we start screening and how often should we screen, they're looking at all this data and then they
Sure.
make a committee decision. So just last year, the United States Preventative Task Force changed the mammogram recommendations. At some point it was like every year, and now they're saying, I think it's 45 to 75. Could be wrong. I don't know this one off the top of
That's
my
okay.
head. I'm
That's all
really
right.
sorry, but it was like every other year.
Yep. Yep. That's what I thought I got changed to too. Yep.
Yeah, but it used to be once a year. And so as they're looking at these data, they say, well, how do, screening decisions for the general population, they come up with those. So, I mean, those are limitations.
Mm-hmm.
So, I guess the overdiagnosis could actually be considered a risk and not a limitation because there
Sure.
is harm for treatment, right?
Yeah.
But
Yeah.
there's other, okay, so now moving on to risks, there's two for sure, three
Yep.
if we're going to call overdiagnosis a risk, but one is trauma. So you're compressing the breast down to a centimeter in thickness.
I've never had one, but it sounds horrible. I
Oh
have
my God,
patients who are
it's
literally traumatized who say, I will never get a mammogram
squish
again. Yeah.
and squish, right? So two dimensions, 45 pounds of pressure to squish the breast into a centimeter so that you can see it. You can, the radiologist has the ability to see things.
Sure.
There's reports of hematomas just from a mammogram that needed surgical drainage. There's implant rupture that certainly can
Sure.
happen. And then the other risk is radiation, right? Radiation is a health risk, and we are radiating women's breasts to screen for cancer. Is there a possibility that some of the cancers that we're detecting could actually have been caused by the radiation? I never knew that,
Mm-hmm.
and the answer is yes. It's not a lot of radiation, it's a little. And so I'm not here to say that the risks outweigh the benefits, but I think it's important that we identify the risks.
Yep.
And so the concern we have with radiation is that we think that it's cumulative exposure. It's not just one. So whatever radiation you have throughout your life, it builds up because the DNA gets damaged and damaged and more
Yeah. Yep.
damaged.
Yep.
And so when you look at these women who are starting to screen in their 20s because they have a BRCA gene or a family history,
Mm-hmm.
and they're getting screened once a year or sometimes twice a year, starting at that very young age, what's the possibility? So there
Yeah.
actually is a study, and I didn't know this until once I learned about the QT imaging and it really made me dive in, like, what do we know? What do we not know? What are the risks? I was amazed when I saw the amount of literature out there that actually has information that I was not taught, and I'm a gynecologist, you know. But a study from 2012 estimated, looking at nuclear bomb survivors and the amount of radiation that they received, and translated it into the amount, and they calculated that for every 100,000 women that get a mammogram, there will be screened annually. So if they're screened annually starting at the age of 40 and then through 55, and then it's 86 induced cancers from radiation and 11 cancer deaths. So that's out of 100,000, right? So it's not a lot, but it is there. And so
Yeah.
I think it's important to identify that. And then another study said it may be significantly more than that. It may be 4 to 6 times more than that, because what we're looking at is DNA damage, and
Sure.
nuclear energy is high gamma radiation, whereas mammogram is low gamma radiation. And low gamma radiation is 4 to 6 more times likely to cause nuclear damage than high gamma radiation. So now we're looking at 430 cases of cancer and 66 deaths.
Doesn't
That's,
sound good. Yeah, it's
yeah.
interesting that you say this because I have a client here, well, patient, who one of her best friends was getting mammograms, like you said, from a very young age due to strong family history, to my knowledge. And it sounds like the doctors fully admitted that they think all the radiation she had contributed to this cancer. I mean, she's in her 40s and this cancer that has been found, which is very scary, very
Mm-hmm.
scary.
So that's the point. And so I think if women are given information, let's
Yeah,
decide based on information, but not shamed into making decisions that we're being, if you decide against it, that you're
right,
being careless with your
right.
health. And that's unfortunate. Doctors in that work in employed positions with these big companies, their reimbursement rate varies. If they're a good doctor and they have a 75% adherence to screening mammograms, then they get a bonus every year. But if they're a bad doctor because they only have a 50% adherence to their mammogram recommendations, then they don't get that bonus at the end of the year. And that's insurance company driven.
Yep. Yep. Which is why we're not in that system. Okay.
Amen.
Yeah. Um, let me go back to the radiation and the cumulative damage. So, what can listeners do to protect themselves against that radiation? So, I typically tell patients to take antioxidants. It's the same thing like when you
Mhm.
fly. If you know you're going to have a
Yeah.
chest x-ray, you fly, you're going to have a mammogram. Do you believe in that? That
High dose
antioxidant?
melatonin too.
Yeah.
Absolutely. So actually 150 milligrams, which is a whopping dose of melatonin, can be very protective against radiation damage.
The day,
And
like
in
the day of the
yes, a
exposure. What
couple
if
hours
you,
before.
okay.
And
So,
then high dose antioxidants for sure.
okay.
But melatonin acts as that. It is an antioxidant and it has been shown to be protective. In fact, there was a study that looked at giving poor little rats, right? They gave rats a lethal dose of radiation, and the ones that had a certain amount of melatonin in their body didn't die from it, and all the other ones did.
That protective. Okay.
Yeah.
So
And it
if we,
doesn't make you sleepy. That high of a dose, because I was like, how are they going to get to and from? Melatonin is the supplement we take to sleep. But at when you cross a line, and I don't know what the label is, but
yeah, yeah. When it's that high, yeah.
when it's that high, it doesn't trigger the sleep response.
Gosh, I want to ask so many questions based on what you already said. So before we go on again to the good stuff, let me go back to, we kind of talked about mammograms. Can we talk about MRIs a little bit? Maybe
Yeah,
pros and cons of those also. You
yeah.
mentioned you're getting, well, obviously it's radiation and you're
Access to
getting the,
care is one, right? Because they're
sure.
not very, they're not all over. So people, struggle. They're super expensive, super time consuming. And then they need to have gadolinium injected because it's magnetic. There's no radiation, so that's good.
Oh, yeah.
But gadolinium is a heavy metal. It's toxic.
And how do we get that out of the body? How do you
Very
help
hard.
patients? Yeah.
Yeah, it doesn't go out easily.
I've
I
tested
think,
patients I mean, well, I shouldn't say years, but a year and even 2 years after.
yeah,
And
it's
then
stuck in there
gadolinium is
just like
still really high.
lead,
Yep.
right?
Yep.
I mean, so I think the standard things that you and I do with our patients to detox them will
Will help.
help,
Yep.
but it's definitely something to consider. But they need the gadolinium because otherwise the MRI images aren't as sturdy. The gadolinium makes the tissue so heavy so that as the magnets are moving, the tissue is stable. Otherwise, the tissue wiggles from the high dose magnetic changes, and so that's the purpose of the heavy metal gadolinium is to make the tissues heavy so that they
Hmm.
don't wiggle with the magnets and make it harder to see the image
And why would one be recommended an MRI? Or wait, I could see how someone would opt for it because they didn't want the radiation, but why else would they
or
be
the
recommended?
compression.
Yeah, or yeah, or the trauma from the compression.
The one of
Yeah,
the other problems with MRI is that it is so sensitive that it probably has a much higher false positive rate. It's going to
sure.
pick up so many things. Here's something for people to understand is that the only way to know for sure whether something is cancer or not is to get a tissue sample. All these imaging studies do is create a likelihood of whether or not something serious is going on. The only way to know for sure is to look under the microscope at a tissue sample and see if it's abnormal DNA and looks like cancer.
Well,
But
now I
that
want to
is
ask
a
you about
very
biopsies and yeah,
aggressive
yeah,
way
yeah,
to do
of
it.
course, of course. I mean, how do you feel about biopsies? Obviously, sometimes they're necessary. I get that, but I have male patients who've had prostate cancer who they believe they don't want to get or it's
Because it tracks
suspected
it.
they
That's a
have.
that's a
Yes.
question we I honestly don't know the answer to that. And I think it's a valid concern.
There's a theory if you poke and prod it, are you spreading
Are you
those teeny
spreading
little
it through the
cells? Yeah,
tract?
yeah. Yep.
Yeah.
Same thing for, a breast
And we know
biopsy.
that happens with laparoscopic surgery. It's been shown that like people who have ovarian cancer and they do a laparoscope, that they have a much higher incidence of cancer at the trocar sites because of the
I
holes
didn't
that
know
are
that.
put in
Yeah.
the belly and the gas that they expand the belly with. So why couldn't that happen with a needle track? But this is where our hands are tied, right?
Yeah, yeah.
The limitations of medicine, it's
So with
rough.
mammogram, other than the compression, yes, I'm thinking accumulation of radiation. With MRI, you have this accumulation of gadolinium potentially. It's
And
a
more
yeah,
high false positives too.
positives. Yep.
So, how many more women are going to be recommended to get a biopsy because of an abnormal mammogram? I mean, an abnormal MRI. The other thing with MRI is that it's not true 3D imaging. So they can approximate, and there's no such thing as a 3D mammogram either. It's two-dimensional with images stacked like cartoon pictures that when you put them all together, you're approximating a 3D image. It's not true 3D volumetric imaging. And there's about a 1 to 2 millimeter gaps between each image that they stack together. And I think it's closer to 2 millimeters. So if there's a 2 millimeter gap and you have a 1 millimeter lesion equally sandwiched between those 2 millimeters, it could miss
Could
it.
miss it. Yep.
Whereas the QT imaging is true 3D volumetric imaging. So
Let's
that's,
get to that. Okay, so
yeah.
so we kind of talked about obviously the limitations and the risks of the current available, decently covered by insurance, depending your
Right.
deductible. Yeah, screening options. But what's the newest, latest, and greatest option that you offer at your clinic?
Yeah, so we do quantitative transmission imaging, also known as breast acoustic CT. It's changed name in the last year because the inventor ended up selling the company in order to have the ability to produce more machines. And so now Canon is involved in the manufacturing of the
Hmm,
machines, which is great. So hopefully this will come out now and be available to more women. Right now, I think there's only 8 machines in the whole country.
wow.
And I can show you a picture of it because it's very cool. So this is a picture of the machine right here. And what happens is the woman lays on her belly, and this
Hmm.
is a warm water bath. And the breast is suspended in the water. So as you lean forward, we image one breast at a time. And this is the visualization. These are the transducers. And they rotate around to get 360 degrees in a spiraling fashion, or all the way through the complete breast tissue from the chest wall to the nipple. So there's no radiation, there's no compression, there's no IV contrast. It's true three-dimensional imaging, and it's been FDA cleared as a breakthrough medical device since 2018.
Amazing.
Yeah. So sound waves, it uses
Yes.
sound waves similar to ultrasound, but much more advanced. So it actually combines traditional ultrasound, which is what we call reflection ultrasound. So sound hits and bounces off. That's traditional ultrasonography.
So if someone
Uh,
had a follow-up handheld ultrasound,
that's
that's
what this would
traditional. Okay.
be.
Okay.
That's traditional. Okay. Then there's the speed of sound through tissue. That's revolutionary. Okay. And so there's validated studies that look at different tissue types and how fast they transmit the speed of sound. So when you combine the reflection ultrasonography, which is the traditional form, with the transmission ultrasonography, which is the revolutionary form, in a true three-dimensional structure, we can get what we call volumetric imaging, which means we can determine the true volume of a lesion. When you're looking at an MRI, you get two dimensions. Oh, there's a 2 by 3 millimeter mass, but things don't have two dimensions, they have three dimensions, right? And especially if you're getting, and you're trying to approximate it because you're not getting true 3D imaging. So the true beauty of QT imaging is that it's for the woman who has the intermediary scan. There's something there. It's not stone cold normal, but it doesn't look severe enough to send her immediately to a breast surgeon. And then what we do is we bring them back in 2, 3, 4, 5, 6 months, depending on the index of suspicion that the radiologist
Sure.
has. And we can compare the size for volume change, because if it ain't growing fast, it ain't serious. And so we can avoid biopsies. The
Yeah.
goal that I see this is, let's avoid those 8 out of 10 biopsies to prove a woman doesn't have cancer.
Mm-hmm.
Yeah, they have to come
Yeah.
back for another image, but I think that's better than going down the biopsy mill and getting a needle in your breast and, all of that with the risks.
I haven't had a mammogram, but my mother has, and she, when we walked out of there, I had my scan first, and I went out to the
Uh-huh.
waiting room, and I on my computer working, and then she came out, and I said, "How was it?" And she goes, "Well, that was painless." She's like, "That was nothing compared to,
Yeah.
the pain from a normal, normal mammogram." So it was actually very comfortable for the listeners. I mean,
Mhm.
I fell asleep. I'm very tired.
Many women do. Yes.
You just lay, you kind of dunk your breast in
We
this
dim the
warm water.
lights,
Yep,
right?
yep,
And we put a
relaxing
little
music. Yeah.
soothing music on. There are a few women, a few cases of women who have discomfort, but it's not from breast compression. So
Yeah. It's just
the
getting in
two areas,
position. Yeah.
yeah, you have to be able to raise your arm above your head. So if you have mobility issues in your shoulder, that could be a problem. You have to turn your head to a side. So if you have neck mobility issues, that could be
Yep.
a problem. That's the only, but so I don't say pain free anymore, because I know that sometimes if you have really mobility issues, then it might cause a little bit of discomfort there. Or if severe mobility issues, then we can't do the scan, because we have to
Sure.
be able to get the breast in the water bath.
Sure. Your assistant or whoever she was wonderful. Yeah, she just walked me
Good.
through what we were doing and she said, "Okay, we're going to start now." She had to get me in position and then the scan starts. I think mine was like 12 minutes each side,
Uh-huh.
something like that. So
Yeah.
she said, "Okay, now we're done." So then you sit up and you rotate and then put the other side in. So
Hmm.
it was very easy to do.
Yeah.
Just for listeners, I guess it almost sounds too good to be true. Like, so I have to ask, have to play devil's advocate as far as, so what are limitations of this, or are there any?
Um, of course there has to be, right? Because this is life. What I have found to be some limitations. One is that if you have very small breasts, then you can't you get the best image when something's hanging
Sure.
into the water bath further, because the cameras, for lack of a better word, the
Yeah, 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 yeah.
probes rotate around the breast. So if a woman only has this much tissue in the water bath, there's not much to rotate around, and you get some blurring from the chest wall
But a
because you can't
mammogram wouldn't be
rotate.
good for her either. I mean,
Right.
there's
Well, they
so
make it
yeah.
work. I don't know how. They just squish like crazy.
Yeah, yeah.
But you're right. Yeah, there's limitations in that. So, so that's really the only limitation that I can see. And the fact that if someone has mobility issues, they're not a
Sure. From a
candidate.
comfort standpoint, yeah.
We cannot do people who have a pacemaker. It's not recommended if they have implantable cardiac things in their chest.
What
We
about breast
don't think
implants? You can still,
it's
yeah,
perfect for
yeah, yeah,
breast implants
yeah.
because there's no compression,
Sure.
right? So there's no risk of
Yeah.
rupture.
Yep. So what about false positives or false negatives? Like, do we know the rate that those occur with QT?
Well, I can tell you in the 11 months that I've been doing scans here, now I should have looked at the numbers, but we've only had one person, two people that needed to have a biopsy after their second scan.
Wow.
All the other people that have had a repeat scan, it was shrinking in size or stable in size over the interval. And so instead of having to be sent for a biopsy,
Yeah.
they were told now to come back in a year, because if it didn't change in 3 months, it's unlikely that it's going to start changing rapidly now.
Yep.
Let's do it in a year. There
Sure.
was one gal who you know, who came in. She was very anxious because she had a mass and they had recommended biopsy. And we were in a transition period where Dr. Clock, who was the inventor, he used to be the one that interpreted all the scans, and now he retired suddenly. And then so December 31 was his last day working, and we had a new radiologist coming in. But as she was getting comfortable doing her scans, there was a delay in getting scans read. So this younger woman in her 40s had been told to have a biopsy. She had her QT scan hoping to avoid the biopsy. She didn't get the results in a timely fashion to her, which I felt bad about, but I couldn't control. And so she went and she had the biopsy done, and she was disappointed because she had hoped to do the QT scan to avoid the biopsy. Well, the biopsy was benign.
Hmm.
And when she did come back for a QT scan later, it hadn't grown. So theoretically, she could
She could
have.
have prevented the biopsy. Yes.
So, there are women though, and this is not for me to decide. So, I get asked this a lot, or I have in my career, how often should I get a mammogram done? And I always ask them, what bothers you more? The fear of cancer or the fear, I hate to use the word fear, or the thought of having unnecessary procedures done to prove you don't have cancer? Because there's two different classes of
Yeah.
people.
Yeah.
We
Yeah.
tend to be a very cancer phobic society, and we're willing to do all sorts of things to put our mind at ease that we don't have cancer. But then there's people who are like, I'll take my chances. I don't want to have all these unnecessary poking and proddings. Then I'm like, well, then
Right.
don't get a mammogram every year.
Sure.
And now that there's options, so that's what I used to tell people before there was options, right? So if mammogram was the only option, but this is not intended necessarily to replace mammogram. At least we cannot market it that way. And I'm
Sure.
not marketing that way. I
Sure.
am trying to have a conversation with people to use it as an adjunct, or if they've decided that they're opting out for reasons that are their right to opt out of,
Hmm.
then this could be an alternative.
Yep. Well, and you're just very pro-informed consent and choice.
Yes.
And yes, let's give women all the information, and then based on their risk factors and their situation, they can make the decision.
Yes.
I have to bring up
Absolutely.
thermography because I've had an episode on thermography, which again,
Yeah.
before you had this scanner, you probably
That was
also,
the only option,
recommended. Yes.
right? The only safe option.
Yes. Can you speak to that just a little bit? Obviously, this is much more advanced than thermography, but can you speak a little to thermography?
Absolutely.
Yeah,
So there's one thing I love about thermography, and that is the principle. And what I mean by that is it acknowledges that cancer is an inflammatory condition. And it's not just a bad luck that the tumor is the problem. It's
sure,
inflammation that's the problem. And so
sure.
thermography picks up heat. The disadvantage is it's not structural, and a mosquito bite, a chest cold, and a tumor are all going to light up red.
Yep, yep.
And so
So
if we look at,
limitations of thermography. Yeah, yep,
yeah, and so if you have an abnormal thermogram, you can't act on that unless you're going to avoid surgery. If you're going to say I'm going to go treat a natural doctor to decrease inflammation and hope that decreases my cancer risk, then yeah, then it will work. But if you're trying to say, okay, here, this is a graphic, and so this is a picture of a thermogram. And so you can see that this woman has inflammation. So green is cool, and red is hot, and yellow is warm. So she's got some body inflammation,
yeah.
and she's got some breast inflammation. And so this would probably, excuse me, show up as an abnormal thermogram. But what does it show? That it just shows inflammation here. So
Mhm.
then maybe that woman would then say, okay, I'm going to go get a mammogram done, or an ultrasound, or an MRI based on that, or a QT scan based on that. But it doesn't show structure
Yep,
compared to this is interesting. So this is a picture, these four, 1, 2, 3, skip the thermogram to 4, is a picture of the same woman's breast issue. She actually had cancer. and this is a cancer picked up on MRI. And it almost looks exactly the same on QT scan.
Hmm.
It's just a different view. This is the whole cross section of the breast and, laying in the water. And this is the side view of the breast laying in
Sure.
the water, or on MRI. But mammogram missed it. Here's the mammogram. It's not seen. Ultrasound picked it up. You can see there's shadowing here.
Yeah.
So this is the lesion right here, and there's shadowing. So she had a mass that mammogram missed. They saw something on ultrasound. They did the MRI. They saw it. It looks very similar on QT scan. So when we look at like radiation free, compression free, no IV contrast, image quality, and then cost effective, MRI is super expensive. Handheld ultrasound, I guess you could call cost effective, but a lot of times insurance companies don't cover the MRI or the ultrasound. That the
They want to
Affordable
cover the
Care Act,
mammogram. Yeah.
the
Yep.
Affordable Care Act has mandated that screening mammograms are covered, but not follow-up views, not additional views if there's a callback.
I
And
didn't
so
know that
QT
either.
is
Yeah.
the only one that has all of them.
So for the listeners, she's just looking at it or sharing a table comparing breast imaging options. So there's a column for mammogram, a column for the handheld ultrasound, a column for breast MRI, a column for thermogram, and a column for QT scan. And she's saying the QT scan is the only type of imaging that's meeting all of those criteria that she mentioned. That's radiation free, compression free, no IV contrast, high image quality, and is cost effective.
Thank you, Dr. Stephanie. I keep forgetting that not everybody
No,
is
that's all right.
seeing this on video. Yeah, but so the thermogram will not show you a structural issue, will not show a lump or a concerning mass. So if there's
It will
something
show
there,
changes in temperature.
changes in temperature
Yep.
only.
Yep.
Which the thing I like about it, like I said, is that it is at least it's on the physiology side acknowledging that it's inflammation that's the problem.
Yep. Yep. So that's literally what it's looking at. Yeah, and that's what my guest
Mhm.
said, who was very pro thermography, that we're looking at physiology.
Mhm.
So if you have an abnormal thermogram, the challenge is then what do you do, right? Then you have to get additional imaging to follow up on that. And yes, you may be able to get a handheld ultrasound, not covered by insurance, maybe pay out of pocket for it, whatnot. Or you could do something like the QT scanner,
Mhm.
sounds like.
Yeah.
Tell me about the iodized water. So I was curious about the warm water, and apparently it's
Deionized water?
yeah. So
Yeah.
why is
Oh,
that? Is that to sterilize
because
it
it
or?
is so sensitive. The sound waves are so sensitive and the detectors are so sensitive that if there's particles in the water, it's going to scatter the image.
Oh,
And so we have this very powerful, water purifier, remove particles from the water, and then it sits in a special bath to get degassed because when you first turn on a faucet, and you fill a water up, there's little bubbles in the glass. We have to make sure all the air bubbles are out of the water because that's how sensitive the scan is. If there's air bubbles in the water or too many particles in the
hmm.
water, it's gonna scatter the sound waves and you're not going to get as clear of an image.
Interesting. Okay.
Yeah.
I was going to ask this question, which you kind of already answered, but I want to just go back to because the listeners are hearing a lot of this content for the first time. So it's okay if we repeat ourselves here. So, what's the difference between a handheld ultrasound or an automated whole breast ultrasound and this sort of QT ultrasound? I know you said this is more of a transmission,
Yes.
but can you say
So
that one more
handheld
time?
ultrasound is completely reflection. And the advantage of it is that it's live, right? So there's a technician moving a probe over a woman's breast who's laying on her back, and the breast is laid out over the chest wall, spread out a little bit. And if she sees an area of concern, she can zoom in on that area and get more pictures of it. So there's pros and cons. If you have a really good technician, then it's a pro. If you have somebody that's in a hurry or in a bad mood or didn't sleep well that night, then it's a con because if they don't go slow enough to find the areas of question and hover in on those areas, then they get missed.
Sure.
So whole breast ultrasound is automated.
Hmm.
And so not all of them are on your belly, but there is a machine, I think it's called the Delphinius or Delphinus, that is a whole breast ultrasound. It looks similar to QT. It doesn't have the ergonomically shaped table. It's just a flat bed, but it is a water bath and it's an automated ultrasound that goes around, but it's not true 3D imaging. The image quality is not as good, and I don't believe they do the speed of sound like QT does. QT is
Hmm.
very advanced compared to those.
Sure. You kind of already answered this question too, but in what areas of breast cancer screening does QT imaging really excel specifically?
Yeah, right. Well, um, yeah, preventing biopsies, right? And
Unnecessary
maybe
biopsy. Yeah. Yeah.
overdiagnosis too, because
Yeah.
if you
Yeah.
don't biopsy it, then you're not going to diagnose one of those cancers that now it's changing. But time will tell on that. I
Sure.
can't promise that, but that's what I'm expecting. And
Sure.
honestly, Stephanie, I think within 10 years, this will be available elsewhere in like regular imaging centers, but we did not want to wait 10 years to bring this to
Yeah.
women. When I heard about it, I was like, women need this now.
Oh,
And
I
so
would love to have it in my clinic. Yeah. Yeah.
yeah,
I
we're
agree.
just doing
Yeah.
it as a grassroots effort, right?
Yep.
No referral needed. Come on in, we'll do your scan. And
When
we're
it sounds
pushing the
like you have people
envelope.
flying in from all over too, because there aren't
Yeah,
many scanners
right.
available. So yeah.
Yeah,
Um, I was also going to ask any contraindications, and you did mention a few of those. Can you
right. We
repeat those?
don't recommend it in pregnancy. Now, that several reasons. A lot of things are not recommended in
Yeah.
pregnancy, right? Number one, the breast, it's hard to lay on your belly in pregnancy for that long. Number two, your breast is changing so much in pregnancy. We
Yep.
tell people wait until you're done,
Yep.
even with breastfeeding, because your
Yep.
everything changes so massively that, wait and then
Yep.
get it done later. So other than inability, contraindicate if they can't climb on the table, if they can't raise their arm above their head or lay on their belly, or if they have the
Pacemaker.
implantable
Yeah.
heart device, or pregnancy, if they have active sores on their breast, it's not recommended because
Sure.
then
No open
we have
lesion
to
going. Yeah.
chlorinate the
Yeah.
water to a tiny amount, in order to keep it sterile, not sterile,
Sure.
but to keep it clean. But
Sure.
if you have a sore on your breast, that leaks into the water and it's going to obscure the vision, and you might get a chlorine irritation. Obviously,
Sure.
if someone has a chlorine allergy, with most people don't, right? But then they couldn't.
Sure. But you kind of already answered also who is not a good fit for this type of imaging. That kind of answered that.
And
Um,
there's a limit in breast size. So if you're less than double A or bigger than triple D, I have it written down. Is it F or D? I mean, it goes pretty large, but it
sure.
has to fit,
Yeah.
right? If a
Yeah.
woman is very, very large breasted, then there's not enough room for the transducer to
Sure.
rotate around it without touching the skin. And we don't want that to happen. There needs to be water in between the transducer and the skin.
Sure. So let me come back around to, what happens if you find something abnormal on the scanner? I mean, it sounds like you're bringing patients back for repeat imaging 6 months later.
Mhm.
Is that pretty common? 3 to
3 to 6 months.
6 months. Okay.
No, it's
Or,
not.
oh, okay.
Well, it's unusually common right now because we're brand new. And so we are getting women who have felt a mass for months,
And they're finally getting an image. Yeah.
but they
Yeah.
didn't want to have a mammogram. And so they were burying their head in the sand, or not necessarily, they were making an informed decision that they weren't going to get a mammogram. And then they heard this was an option. And so they're like, I'm going to go get a QT scan. So we have a lot of people
Yeah.
coming in that would qualify as a diagnostic mammogram. We don't call it a diagnostic QT scan because it's the same scan. The reason they call it a diagnostic mammogram is they do special views, but the QT scan's the same, whether it's screening or diagnostic. So we don't call it that. But if you're coming in with a breast mass, then of course there's likely that there's going to be a
Gonna be
follow-up.
follow
And we
up.
have an
Yeah.
inordinate number of people coming in because they have a pre-existing concern.
Sure. So on that follow up, you're going to look at stability, like you were kind of saying for the audience to kind of dumb this down. You're going to look to see if something's growing or shrinking. Like you said, if it's
Yeah.
shrinking, that's a good thing. If it's growing, that's not a good thing. So would there be cases where something, it sounds like you've only had a couple, but where you do see something abnormal that you are recommending a biopsy for? I mean, this can detect cancer. There might be
Yeah.
something, yeah,
Well,
abnormal.
and again, I think it's very good at predicting whether there's going to be cancer there, but prediction is the word, right? The only way to know for sure is to
It's a
put a
tissue
needle in
sample.
it,
Yeah.
tissue sample. So we have had women, and this is where autonomy comes in. So we have had women who the radiologist interprets the scan and says, this looks worrisome. You should go see your trusted provider. And, in the traditional medicine world, we call that your breast surgeon to get this treated. Well, we've had women who are like, I don't want to get a biopsy. I'm going to go work with an integrative doctor and do unrisky cancer things. Let's get rid of inflammation. Let's do maybe hypothermia, whatever. We don't treat cancer here, but there are women who are going to these centers
Yeah.
and then coming back later to measure change size based on the interventions that they've done. But when we have two ways of notifying people. If it's a normal result, we send them a standardized message. Good news, you have your results available in your online medical record, and they can go pick up their report and see that it was normal. If there's anything concerning, then we do a courtesy call to say, listen, this was the finding. Here's the recommendation. Almost always the recommendation is repeat a scan somewhere between 2 and 6 months.
Sure.
Would you like to have that here? We'll get you scheduled right away. Or like I said, in 2 times in 11 months, it's been, there's a finding here, and the radiologist is very suspicious that it could be cancer. So we're not recommending a repeat scan. We're recommending immediate evaluation.
Sure. Okay. Good
It
answer.
also picks up implant rupture. We've had a few people who've come
That's
in with
cool.
implants and
Yeah.
it's picked up rupture, and those ones are
Wow.
told to go follow up immediately too
Yeah.
because of rupture.
Yeah. Interesting. That's good to know in case, yeah, I have a suspicion with the patient. Interesting. You mentioned that you like that thermography detects inflammation. So I actually want to digress and go off on a tangent here really quick because I know you have feelings about positive ANAs, which we're checking in
Mm,
most of our patients. Do you briefly, as we sum up the show here, briefly want
yeah.
to comment on why you feel positive ANA is often a ignored red flag?
Oh, 80% of autoimmune disease is in women, and most of my patients are women, so this is a passion of mine. It's a red flag because it's showing immune system dysfunction. And there's about a 10-year time frame between when you have immune system dysfunction before you have a diagnosable disease. And over again, I've had women come into my practice who have been said, yeah, I knew I had an ANA positive a few years ago, and my primary care doctor sent me to the rheumatologist. And the rheumatologist did all these tests and then said, yeah,
Said you're
but you don't have
fine.
autoimmune disease. Come back later, and then I'll treat you with what, methotrexate or a steroid or, some biologic that suppresses your immune system. And it's like they're not given anything to do between this immune system dysfunction and the disease. And the only
Hmm.
difference is end organ damage. If you have enough end organ damage, then they call it an autoimmune disease. But if all you have is immune system dysfunction, but no end
We
organ
don't care
damage,
about it. Yeah.
then
Yeah.
they say come back later.
Yeah.
And that drives me crazy because it's so treatable. I've seen it reverse with doing the right things, as I'm sure you have too.
Oh,
And so
absolutely.
it's like
Mention some of those basic
the
things for our listeners.
I want to see women request the scan. I mean, request this test. And if it's there, it's a red flag. Business as usual is not working. You need to make some serious changes because you're on a train track headed for disaster. But you can change it.
And then you can reduce inflammation in your body using functional medicine principles. Change your diet, reduce your stress, improve your sleep, all these things. Yes.
All these things. Get rid of the toxins that are
Oh,
confusing your
yes.
immune system.
Heck yeah.
And mold is a big one.
Yeah. Yes. We talk a lot about that on the show. So, anything else you want to add that you haven't been able to share yet about the scanner or your practice, your
I just
passions?
want to encourage your listeners that these are, we're trying to empower you, right? Don't just take recommendations, ask questions. If your provider will not answer your questions, get another provider. And you deserve to understand why you're having something done, and you deserve to be empowered to make your own decisions and not just told to do something because that's what some United States task force says to do.
Tell us, Yvonne, where your practice is again, where listeners can find you and your scanner.
Yeah, so I am in Crystal Lake, which is a Chicago suburb, and we're 45 minutes from 55 minutes from O'Hare Airport. So you can get to O'Hare direct from almost everywhere in the country. So and we are doing the scan. We do offer the scan to people just walking in. I mean, with an appointment, right? You don't
Yeah,
need
right,
to
right.
have a
Yeah, yeah, yeah,
referral
yeah.
from a
Yeah, yeah.
doctor. They can schedule online. Um,
Yep.
I have a YouTube channel, which is Yvonne Karney MD, and I have Instagram also, Yvonne Karney MD. And so I'd love to be able to share health tips just like you do for people.
Yeah, and we'll put links to all of that on in the show notes.
That'd be
So,
great.
so tell us, last but not least, what your top longevity tip is.
And I'm laughing a little bit with that ask because we talked a little bit before and it's sleep. And to me, it was a huge one because one of the reasons I started getting into functional medicine was as an OBGYN, I wasn't sleeping. You know, babies come at unusual times of day. And I thought, okay, I just need to support my body better. And if I start taking supplements, then I can, you know, keep doing all this. And I started learning all these things. And every lecture that I went to, somewhere in the middle of the lecture, they say, but remember, you still need to sleep. You can't out sleep. I mean, you can't out supplement lack of sleep. So whatever is impeding with your sleep is probably the number one thing to change because you don't get sick just from exposures. You get sick because you can't heal.
Hmm.
And if you're not sleeping, you're not healing.
And even back to that immune system dysfunction thing. That's where you
Sleep,
got to,
yeah.
yeah, yes, you need sleep to nurture your immune system. Yes, that was awesome.
So all those hacks out there are great, right? Biohacking tools, but really,
You got to
you
sleep.
can't out
Yeah,
biohack lack of sleep either.
100%. Well, I'm so happy that you're offering the scan. I'm happy that my mother and I got to experience
Yeah,
it for ourselves. So I just want to thank you for being the pioneer and the grassroots of, offering this QT imaging and for sharing today why this is really changing breast health screening. This was exciting. So thanks again.
my pleasure.